How do pathologists differentiate pancreatic cysts? Imagine trying to solve a mystery inside the body. When doctors find a cyst in the pancreas, they need to figure out what kind it is to decide the best way to treat it. Pathologists play a key role in this process by examining tissue and fluid samples carefully. Pancreatic cysts are diverse, and understanding their differences helps prevent unnecessary surgery or catch cancer early. There are several main types of pancreatic cysts. Pseudocysts are not true cysts but collections of fluid that often form after pancreatitis or injury. They usually do not contain mucin, a thick, mucus-like substance. Serous cystic neoplasms are generally benign and filled with clear, watery fluid. They often look like many tiny cysts grouped together and are more common in women. Mucinous cystic neoplasms are more concerning because they can become cancerous over time. They usually have a single large cavity and contain mucin. These are also more common in women and tend to appear in the body or tail of the pancreas. Intraductal papillary mucinous neoplasms are premalignant and can develop into invasive cancer if left untreated. They produce mucin and involve the pancreatic ducts, often causing duct dilation. To tell these cysts apart, pathologists relying on a combination of imaging, fluid tests, and genetic analysis. Imaging techniques like computed tomography scans and magnetic resonance imaging help visualize the size, location, and internal features of the cysts. For example, a cyst with septa or solid parts might suggest a neoplasm. During a procedure called endoscopic ultrasound-guided fine needle aspiration, doctors collect fluid from the cyst. This fluid is then tested for markers like carcinoembryonic antigen, which is often higher in mucinous cysts, although it is not perfectly specific. Amylase levels in the fluid can indicate communication with the pancreatic duct, which is common in pseudocysts and some intraductal neoplasms. The viscosity of the fluid also provides clues. Mucinous cysts tend to be thicker. Genetic testing adds another layer of information. Mutations in genes like CRAS and GNAs are frequently found in intraductal papillary mucinous neoplasms. Other mutations, such as in CDKN2A, PIK3CA, SMAD4, and TP53, may point to more advanced or potentially malignant changes. Combining all this data helps pathologists classify the cyst accurately. Getting the diagnosis right is vital because it guides treatment. Benign cysts like serous cystadenomas often do not need surgery, while premalignant cysts like mucinous types might requiring removal to prevent cancer. The decision depends on the cyst's features, the patient's overall health, and the risk of malignancy. In summary, pathologists differentiate pancreatic cysts by carefully analyzing imaging results, fluid markers, and genetic mutations. This comprehensive approach ensures that patients receive the most appropriate care, whether it is monitoring or surgical intervention. Always remember, if you or someone you know has a pancreatic cyst, consulting a healthcare professional is essential for personalized advice and management based on the latest scientific evidence.